So this is a 54 years old male patient who is a known case of hypertension, presented with the CADSS inferior wall ST elevation MI, and this is the angiogram. He presented within the 2 hours of his chest pain, and this is the ECG. There's a ST elevation in the 2-3 AVF, 3 more than 2, so probably culprit is the RCA, and this is the angiogram, a levocaudal view. And you can see the distal LM, there is a lesion. LAD also, mid LAD there is a lesion. LCX also, small vessel and proximal lesion. This is the ariocaudal view, and you can see the lesion in the LCX, proximal LCX, and distal LM, and this is the epicranial view, and you can see the right from proximal to mid there is a significant stenosis in the LAD. This is the ariocaudal view, and you can see the same thing. And as this patient presented with the ST elevation in inferior leads, 3 more than 2, obviously the RCA is the culprit, and you can see the right from the proximal RCA there is a total occlusion. So at the time of angio, patient when I inject the RCA, that time patient got VT. So we decided to do the plasty. So with the right radial route with the JR catheter, this is a workhorse wire BMW. So I tried with this wire, but wire was not crossing. I tried for the 10 minutes probably, but it was buckling and not crossing. Wanted to do with the balloon support, but I tried then a whisper wire, and this is a whisper wire, and you can see wire has crossed, but flow there was no flow. This patient presented with the 2 hours of index pain, and this is the condition you see after crossing even wire. This is a whisper wire crossed in I think 2-3 minutes, but there's no flow. So I thought of doing balloon dottering, but somehow after some progression of the wire into the PLV, I got some flow in the distal RCA and PDA PLV. So I thought I will directly stent. Meanwhile, patient got again 1 episode of VT, and then I prepared the stent 3x36, and this is a DES 3x36 right from proximal RCA. The stent is being deployed at 12 atmospheric pressure. Nominal was 9, RBP was 16, and this is a picture of post angioplasty, and you can see how the RCA was dominant, super dominant. You can see there how large the PDA PLV, and you can see some haziness at the point of occlusion, and some haziness, probably thrombus in the PLV, but that PLV is very small, almost 2, so we left it. And about this, so at the proximal stent there was some under expansion, probably that was the site where the occlusion was. So meanwhile a patient had 2 episodes of VT, and so we have given the tyrifibin and nicorand and everything, and then the patient was finally stable. BP has come up, and patient shifted to ICU. So this was the angioplasty to RCA, to the totally occluded RCA.